Today, what I want to do is tell you about the All of Us research program and directions that we are taking toward understanding the impact of environment on health and disease, and some of our initial forays into the exposome. I would first like to reflect for a moment on the power of longitudinal population studies to give us insights into risk for disease and factors that impact health. Last year, we celebrated the 75th anniversary of the Framingham study that began enrolling participants in 1948. Just 12 years of observation, and in just over 5,200 men and women, that study gave us seminal findings that are well known to all of you about the association of tobacco products and high cholesterol with ischemic heart disease and stroke, and later added obesity, diabetes, and hypertension to the risk for these diseases. The 1961 paper that you see at the upper left was the first time, I believe, the term factors of risk or risk factors appeared in the medical literature, and was also, I believe, the first time that an observation was made about an environmental exposure, in this case, tobacco use, was associated with heart disease risk as well. Recently, George Mensa, a colleague of mine at NHLBI, published these observations on the decreasing rates of death from heart disease and stroke beginning about 10 years after the 1961 paper on risk assessment was published. And this diminution in rates of death from heart disease and stroke are largely attributed to the risk assessments from Framingham becoming part of clinical guidelines and public health efforts to reduce tobacco use and also reduce cholesterol. And as these began to take hold, you can see the precipitous drop in these rates over the ensuing several decades, even today. And this impact was achieved by observations on only about 5,000 individuals over time. So now imagine what is possible with a cohort of 1 million people donating their data to create one of the largest and most diverse data sets of its kind. Currently, with data available from more than 500,000 participants, and with more than 80% who identify with communities underrepresented in biomedical research, meaning that these people have largely been absent from research studies. And more than 45% self-identify as non-white, again, from racial and ethnic minorities who, for the most part, have not been part of research studies. In 2021, we articulated our 5-year goals for the program, targeting 2026 for completion of these. The first at the upper right is to enroll 1 million participants who reflect the diversity of the United States. The second goal in green is to develop an expansive data set for these 1 million participants that includes survey data, electronic health record data, genomics, physical measures, environmental data, and even wearable digital health technology data. The third goal that you can see at the bottom is to launch Ancillary Studies, a platform that enables us to bring new data into the cohort that was not part of the original IRB approved core protocol. On the lower left in yellow, you see our goal to establish a diverse community of 10,000 researchers productively using All of Us data. And the fifth goal at the upper left is to return value to participants, starting from returning information from the electronic health record, but also expanding our return of results to other types of data that we'll talk about in a few moments. Last year, 2003, we made really significant progress in the program. We consented our 750,000th participant, and we're well beyond that at this point, with over 500,000 core participants, meaning these are individuals that have donated their electronic health records, provided samples for genomic sequencing, and completed a core set of survey instruments that we have asked them to complete. We also have maintained our diversity goals with 81%. UBR is our acronym for underrepresented in biomedical research, and over 46% of our participants are still non-white by race and ethnicity. We collected over 500,000 biospecimens, and we enrolled our first pediatric participant. Up until December of 2023, our enrollees were only 18 years and above, but now we're starting to enroll participants 0 to 4, and then we'll go on to 5 to 13, and then 13 to 18 and over the next several years. In terms of research, we're well on our way to surpassing our goal of 10,000 by 2026, having over 8,400 researchers in 2023 actively using our data. In April of last year, we released 245,000 whole genomes and 312,000 genomic arrays. At that time, it was the largest publicly accessible genomic data set in the world. And we've begun late last year expanding our research community to the international audiences, international researchers, with over 31 institutions having completed our data use and research agreements on 6 continents, including institutions from low and middle income countries. I mentioned that we return value to participants. So last year, we reached the milestone of 170,000 participants receiving their genetic ancestry and traits results, and over 90,000 had received health-related return of results. In terms of our ancillary studies, we launched 2 last year. One, an extensive program to understand the impact of dietary exposures and nutrition on metabolism and health. That's called Nutrition for Precision Health, as well as an app-based cognitive testing platform called Exploring the Mind that we're doing with the National Institute of Mental Health. And finally, last year, we celebrated our 5th year anniversary. So this is from our perspective, an amazing accomplishment only 5 years into our journey to have accomplished this much. I mentioned that we are returning results for genomic data. On the left-hand side, you can see that we return results on genetic ancestry and traits. The ancestry data details individuals' origins for 7 regions around the globe. And we also provide information on traits such as bitter taste perception, cilantro preference, earwax type, and lactose intolerance. We believe those are not really medically actionable and important. But in the middle and on the right-hand side, you can see the health-related return of results. We have a hereditary disease risk report that reports on actionable variants from 59 genes that have been designated so by the American College of Medical Genetics and Genomics. And you can see an illustrative report in the middle. And on the right-hand side, we report data on pharmacogenetic variants for 7 genes that is dictated by the Clinical Pharmacogenomics Implementation Consortium guidelines. And as you can see at the bottom, as I said before, over 170,000 individuals have received their ancestry and traits since 2020. We began returning health-related return of results in December of 2022 at a rate of 5,000 per week. The frequency of having an actionable variant from the hereditary disease risk report is about 3%, so a little bit above unselected populations from other cohorts. And the pharmacogenetic actionable variance in the pharmacogenetics report is over 95%. In fact, our data shows that more than 30% of our participants are on medications that could be impacted by their pharmacogenetic variants. Now, a year ago, we developed and released the first version of our scientific roadmap and priorities for the program. This was pretty much on me as the Chief Medical and Scientific Officer. Well, time will not permit me to go through this in great detail. I just want to point out that this is a 2-dimensional representation of what is a 4-dimensional plan with great depth beyond what you see here, as well as a time horizon for the implementation of the science in these strategic focus areas. But I'll take you through it briefly. At the bottom is let me start at the top. At the top is the overarching goal in pink that you see of advancing precision medicine and population health for everyone. And for everyone really is meant to reflect the diversity of the US population. But at the very bottom is the starting point, our core data set, illustrated in gray, which includes what I've told you before, the electronic health record data, survey data, physical measures, digital health technologies, genomes, and assays. And just above that is the workbench and toolbox that will enable researchers such as yourselves to fully access and optimize the utility of that data for any question you want to answer. Above that layer are what we're calling exposures and drivers. These are 4 areas of research that we believe are critical to the understanding of how we maintain health and health to disease transitions and their lifestyle, such as sleep, physical activity and diet, environment, health inequities, and the stressors that are related to health inequities, as well as our fundamental genetics and biology. Responses to exposures and drivers are in the research areas that we call causality and outcomes above that layer. These include, on the upper left, the top 10 causes of morbidity and mortality for the United States. Second to that is maternal and child health. To the right of that is healthy aging and resilience. And then on the far right is the impact of data and information that we return to participants on their health decisions, so an outcomes research agenda. Important for this audience, I think, are the environmental exposures. So I'd like to just drill down for a moment on that particular area. So this illustrates some of the other dimensionality that I talked about. These are at least the first 7 opportunities that we think are important for our agenda in environment and health. The first is to assess personal, residential, and occupational histories. I'll tell you more about that in a moment. The second is to integrate environmental data and climate data using data linkages with our core data set. I'll tell you more about that in a moment. The implementation of sensor data, either on the person in their residences or in their occupational areas to capture that type of data. And then downstream of that, with some time, we hope that the community will begin to develop novel quantitative risk assessments and predictors of disease progression based on environmental exposures and the exposome, and specifically to develop exposome profiles for disease incidence, and to include in that an opportunity to develop biomarkers of exposures that are at the host level. So we call that biodosimetry. And then finally, I guess the ultimate goal is to develop long-term understanding of environmental risks and health outcomes to inform both policy decisions as well as risk mitigation strategies. So I was really pleased just a month ago to see the first, what I think is some of the first environmental data coming out of the All of Us research program, a study of air quality and cancer risk using PM 2.5 linked to 3-digit zip codes for our participants. So on the right-hand side, you can see that these data were captured in 400,000 participants, who had 10% of which had a cancer diagnosis in the electronic health record, as well as incident cancers that could be seen in the EHR for the ones that you see here, and the association with those cancers with increased exposures associated with PM 2.5 levels. On the map on the left, you can see where these data were largely ascertained based on our health provider organization locations in pink. And again, so we have some higher density around those and lower density in areas where we don't have active recruitment sites. But I can tell you this is very exciting, and environmental data is one of the top requests that we have from researchers in our researcher community. So that's why environmental and exposome data is such an important aspect of our strategy. We also funded late last year something we call the Center for Linkage and Acquisition of Data, or CLAD. And CLAD is really meant to use data linkages explicitly to collect health-related data, environmental data, and mortality data. So specifically, geocoding allows us, and residential and occupational history will allow us to get time-dependent geospatial data for our participants, and link that first to the CDC's Environmental Justice Index, and then in the future to other data sources as might be from NASA or NOAA. We're also going to have, during the first 18 months, fill in a lot of the missing data from the EHR using health information exchange and other claims data, as well as mortality data. And at the bottom is an illustration of what we would really like to achieve for any of our participants, really understanding their life course and where they have lived over that life course and have essentially a time-dependent series of snapshots of their exposure data, depending on where they lived and the duration that they were living in those locations, and realize those exposures. So we've been working very closely with the National Institute of Environmental Health Sciences, and this is our general approach, both with them as for the program. So on the left are things I've already told you about. We're collecting both surveys as well as establishing data linkages so that we can integrate location information with exposure information. This is being done through the Center for Linkage and Acquisition of Data that I just showed you. We also launched a survey in 2022 to our participants on social determinants of health. We've had more than 100,000 respondents to that survey, and that continues to grow. And we intend to launch an environmental exposure and occupational health survey to participants that I'll tell you more about in a moment in early 2025. In the middle is the opportunity that we're looking for in the future, which is geocoded linkages to GIS data of the types that you see here that many of you probably work on. And then on the right, the topic of today's symposium is on exposomics. The term, at least the way we understand it and use it, is high-resolution mass spectroscopy to look at various analytes. And with NIEHS, we're focusing our initial studies on type 2 diabetes, but we are actively expanding to other chronic disease areas as we speak. So this is an illustration of the Environmental Exposure and Occupational Health Survey framework that we're using to be launched roughly a year from now. We want to look at both residential and occupational histories. Some of the details here, you can see the kinds of things that we're asking participants, the number of homes or dwellings they lived in, or the types of jobs that they had, specific location information, how long and when they were in those locations. And then at the bottom, we have specific questions, depending on whether it's residential or occupational, about the types of exposures that individuals might have experienced. I'm not going to go through this in detail, but you can see a lot of home-related things are things that you might expect. And then there's more types of chemical or pollutant exposures and transportation use on the right for occupation. So I'm happy to share these survey data specifics with anybody in the audience who's interested in them as we develop them. And we're also aligned very much so, and taking, I think, tapping into or leveraging the full National Institute of Environmental Health Sciences Exposure Science and Exposome program, really trying to learn from our participants about their external exposures, their internal exposures, and using the data that we're collecting to elicit the biological responses, building in a layer of tools that will allow the researcher community to take full advantage of that data, with the end game being to really understand exposure, disease risk associations, gene by environment interaction, and to develop collaboratively strategies for treatment, intervention, prevention, and risk mitigation along those lines. We're also with NIEHS taking advantage of their HERE network, Human Health Exposure Analysis Resource. This is a platform predominantly of high-resolution mass spectroscopy that gives information on nutrient metabolites, dietary and food-related metabolites, pharmaceuticals, as well as some of the metabolic byproducts of pharmaceutical exposures, environmental chemicals, all with a very explicit data quality framework. And we've already begun to use the exposome assays as part of the Nutrition for Precision Health program that I mentioned to you earlier. And we're going to begin the type 2 diabetes program with NIEHS in a few months later in 2024. This community is probably very well aware of the kinds of things that one might measure under such a platform. So this is an example of what the HERE platform can do in terms of environmentally relevant metabolites, food-related metabolites, and importantly, not just identifying exogenous compounds that could be detected in blood, but also learning how those compounds might impact metabolic programs and folate metabolism, amino acid metabolism, and the like. So we really get a full picture of both the environmental perturbations as well as how they perturb metabolic profiles in these individuals. Why diabetes? Because it's one of the most prevalent diseases in the country, as well as in our data set. We have about 55,000 individuals with type 2 diabetes and fairly significant incidence rate. On the right-hand side is a fairly recent publication illustrating where the evidentiary basis for exposure-related data on type 2 diabetes. This is how elements of the food environment, the built environment, the physical chemical environment, and social environment are all related to type 2 diabetes, highlighting the opportunity for pathways in which the external exposome, the specific external exposome, and the internal exposome might interact. And the evidence in many cases is quite strong and consistent. In other cases, it's somewhat weak and inconsistent and anecdotal. And it's our hope that our studies will contribute to the evidence base and highlight important biology and actionable insights for this very important disease. I'm almost done. So the last thing I wanted to share with you is that we are very interested in climate and health. On the right-hand side is the illustration of the climate and health strategy within the NIH. On the left-hand side are areas that we are specifically trying to apply to the All of Us research program, specifically in adaptation research and with a focus on heat with the Texas A&M University rapid response protocols and behavioral risk factor surveillance system. We're hoping to learn how individuals respond to extremes of climate as well as acute climate events. This is primarily manifest as the Disaster Research Response Group at NIEHS or DR2 that has developed protocols for this, and eventually to look at the impact of some of these exposures on other facets of health, particularly mental health and well-being, as well as the respiratory, reproductive, and other risk-related behaviors. So this is a work in progress, something that we're really interested in doing. And then lastly, I'll just say this is kind of my call to action slide, and I'm a newcomer to this field, to be honest with you. I'm not an environmental health scientist, but as I've thought about the strategies here, it's very clear, and I think this is a great group that's assembled here at this conference to think about commonly agreed upon conceptual frameworks to develop the questions and understanding of exposomics, to also think about common ways that we apply technology and methodologies and best practices for the field. It's, again, my early understanding of this is that there isn't necessarily a unified approach. And of course, to build a very robust community of researchers that can share this information with one another. I put here at the bottom is my own I guess, call to action for this community from the All of Us research program's point of view is really to develop a consensus on return of results for exposome information to participants and patients, because I think this is really where the translational piece really can have an impact on individual and public health. And I'll close with just this last slide, which is, you may have seen this in yesterday's New York Times, an opinion piece by Justin Mankin from Dartmouth College, pretty much saying that people, particularly when it comes to climate data and climate analysis, that people really want to know what's facing them. People and companies want to adapt to the climate risks they face from global warming, and freely shared information will save lives. So I resonated with that, and I thought that I would close with that as part of the call to action of figuring out how best to provide the most actionable information to participants and improve public health. And with that, I thank you.